Well, hi everybody. We're actually getting ready to go live on Instagram as well. So
I'm live.
okay, so we're live on all the streams. We're trying out a new software, and I am just honored to have the esteemed Dr. Karen Herbst to talk about this prestigious award we got from the Plastic and Reconstructive Surgery, and also to answer questions. So hope people are around. We've already gotten some questions sent in, but welcome, Dr. Herbst.
Thank you. It's great to be here with you, Dr. Wright. I always enjoy our talks together because we always come up with really cool stuff.
Yeah, yeah. Oh my gosh. And I just saw, yeah, we've already gotten some questions, and one we're definitely going to hit is on the stages. And I actually just saw back the patient. You are, your thoughts about maybe even there's 3 stages, but you're even thinking about adding point 1.5 and 2.5.
Mm-hmm.
Yeah.
Yep.
Yeah.
Yep.
So that's super exciting. I wanted to talk a little bit. Well, we're starting off in the biggest news we have. We have a lot of news, don't we? But
we do.
Well, we could just share news.
We can.
the biggest news is, of course, is we won this award, the best reconstructive paper for last year from PRS Global Open, and that's huge. I mean, now you were. This is quite an honor, and of course, you were the lead author on the one that won a couple years ago, and then
so we won in together because we were both authors on that paper. So we won best paper of the year. I mean, of the year. You know how many papers get published in these journals? A lot. And so this is the best plastic and reconstructive surgery paper of the year in 2022. And then we didn't have a lot of papers published in 2023 other than some like really important case reports. But then here we are again, best paper of the entire year, 2024.
Yeah, but I mean, I could not. I mean, I am so lucky to be able to work with you, and I mean, gosh, I mean, what a great team we make.
I think what people, some people may not know. There may be a lot of people in the audience who do know, but some people may not know the different steps it takes to get a paper written. And I just remember in the very beginning, just the incredible amount of data that you and your team had collected together, and trying to get that all down on paper to the point where we were, remember we would get onto a Zoom and we would nitpick over, we'd have one sentence, we'd say everything's good, but this one sentence, and we would rework it, just one sentence. So
yeah,
and then it was done.
Well, I mean, but I mean, it was the paper. The original draft of the paper was like twice as long as, so
it was like 30 pages long.
Yeah, 30 pages long. I know, and I and every word was important, and yet I had to basically cut half of it out, or a little, actually more than half of it out, and it was just crazy. It was so hard, but all the edits and reviewers' comments and stuff did make it a better paper. So
it really did.
Yeah.
Oh, well, it made it such a good paper that it won Best Paper of the Year award for 2024. Amazing.
Yeah. So I, you
And
know,
so you're going to San Diego to accept the award next month, right?
that's right. Yeah. So I'm gonna go to the Plastic and Reconstruction PRS their meeting in San Diego, their annual conference, and accept the award. Yeah.
Wow, that's great. So exciting. We need photos.
Yes. Yes. And I mean, yes. Well, thank you. Yeah, no, I want to do photos. I don't know. I was hoping maybe you could come, but I will understand if you can't.
Yeah, I'm still looking at it. I got a lot. September's a pretty busy month. For example, we're presenting the ICD-10 codes for lipedema to the CDC on the 11th.
That's right. And so that's the next big piece of news. That's next week.
Yep. Well,
And
kind of next week, but the week after next. But yeah, it's coming up really fast.
yeah.
And it's going to be at 11:15. No, sorry, 2:15. That's the estimated time.
Oh, that's great.
And
So
yeah, 2:15 is the estimated time, but we're like 24th. So they said, they cannot guarantee when we'll show up. So we're going to try and get on early.
So thank you. So, cause I was going to try and move around some surgeries, but I think I'm okay. I think that's going to work for me.
Great.
And then, this is, I mean, can we talk a little bit about that? So I'm not seeing any, please, if anybody can answer question or send questions in, and we're happy to answer them. So but while you guys are thinking of questions, or I do want to talk a little about this ICD-10 thing, because this is like you've been working, Dr. Herbst, you've been working so hard for this for so many. I mean, this is 4 years. This is
4 years. Yeah. So, and the thing is, we're down to the nitty gritty, and I get deadlines. Like, I'll wake up in the morning and I'll check my email at like 7:30, and they say, this is what's going on. You have to have an answer back to us by 3 p.m. Eastern time, and I have a whole, I have a full clinic in the morning, and I'm like, so I just shove everything aside and I start working on it and get it done and get it out, because otherwise, I don't want to miss a deadline. I want this to move forward. And the interesting part about these ICD-10 codes is it's not just about lipedema, because in there we have, we worked with Dr. Linzer, let's just say, from the Pediatric Society, and he wanted a code for idiopathic edema. So that's in there. And then there was a mistake on hereditary lymphedema. It was actually in the wrong part of the ICD codes. It needed to be under hereditary. And so we moved that. And then we made sure that there is a code that says Derkum's disease. And there's also a code for multiple symmetric lipomatosis and other lipomatosis disorders. So we hit lipedema, lymphedema, Derkum's disease, multiple symmetric lipomatosis, and which is also known as Madelung's disease. And that includes familial multiple lipomatosis as well. So I think we got it all in there. And we didn't mean for that to happen. It just morphed into that, because once you add in codes for lipedema, other things needed to be moved around. And so it's a big, big presentation. And not only do we have stages in the ICD-10 codes, but we have the different phenotypes, the different types now, so that if you were to if your arms were affected and your legs were affected, your doctors could, or your healthcare providers could code that, and that gives more information to your physical therapist, so they know, I got to treat the arms and the legs, and to your surgeon, so they know that they have to treat your arms and your legs. So I think it's not perfect in the sense that we know that the stages and types aren't exactly great, but I think it's the best that we have, given the stages and types as we have them right now.
Yeah. So I'm so we got a question come in. What's the title of the paper? And I'm putting in the link, and now the title of the paper as well. So yeah, the stages. So sorry for the distraction, but yes. So there's 3 stages. Can we talk about that, please?
Yeah, absolutely. I think there was a big discussion about the stages, and we recognize that some people refer to stage 4 lipedema, and the other word for stage 4 lipedema is lipolymphedema. So that means lipedema with lymphedema, and we feel like you can get lymphedema at any stage of lipedema.
Right.
But of course, it happens more often in stage 3. But we felt like if somebody was stage 2 lipedema, has also lymphedema, are we going to call her stage 4? Well, no, because the stage 4 really refers to more of like a severe stage 3 lipedema. And so what I feel is appropriate, and we went, and I promise you, we had a lot of discussion on this. This was not taken lightly at all. But I follow I'm going to get to it. I follow the Meyer, Vollrath, and Schmeller paper from 2004. And they classified lipedema to 3 stages. And then depending on the visual and other findings of the adipose tissue, into the 5 subtypes. And so I've looked at a lot of other authors and how they present in their papers, and it just seems like most places go up to stage 3 and they don't include stage 4. And I just think it makes more sense to really say, what do you have? You have lipedema and lymphedema at the same. So it's clear what you have, and not necessarily get confused in that staging. Because if you say, I have lymphedema, someone will say, oh, you're stage 4. And you say, well, actually I'm a stage 2, but I also have lymphedema.
Right.
So anyway, I think it's makes it clear to describe exactly the different comorbidities that you have if you have lipedema, rather than saying you have stage 4 lipedema and then just not really saying exactly what you have.
Right. And that's a great explanation. And I would also add to that, kind of amplify on that, is the original stages and the stages as we use them are just descriptive of the lipedema tissue. And then so they don't say anything about, and they don't say anything about lymphedema or lymphatic impairment. And as you know, as everybody knows, lymphatic impairment can occur at any stage. And so, otherwise it kind of, you can actually have, as you explained, can contradict yourself when you say that. If you try and say they have stage 2 and 4 lipedema, that doesn't make sense. So, so I mean,
well, you still got to do that, unfortunately. So let's say you're okay. So the way that the phenotypes, or they call them subtypes, are presented, some authors say type 4 is arms and legs affected, and some others say just the arms are affected. Oh. And so what we chose to do is to say type 4 is just arms, because you're already accounting for legs as type 1 hips and buttocks, type 2 down to the knees, type 3 down to the ankles. So those are your legs, or type 5, just the lower leg. So you describe the legs really, really well, 4 different types. So type 4 is just the arm, or that the arms are affected. And so you're going to add that to your leg description.
I think I have to correct myself. I think I misspoke. So you can't have stage 2 and stage 4.
Correct. Yes.
Yeah. So and I said type, and I meant to say stage.
Okay. Perfect. Yeah, that's exactly right.
I'm so and so let me, oh my gosh. So I just because I misspoke, I want to make sure it's clear.
Okay.
There are 3 stages, this many stages, and there are 5 types. Type refers to where it occurs, and stages is is a description of the severity of the disease, or the amount of tissue. So those, and please forgive any. Thank you for correcting me, and please forgive anybody who I confused.
I think
Please
we got it
forgive-
straight now. So 3 stages, 5 types, and not perfect. Absolutely, we agree, but we feel like it's a great step forward to better describe a patient who has lipedema.
Yeah. So there's more questions coming in, but there was one other so there's a question about vascular compression syndromes. Any and I'm going to let you handle that,
Okay.
Dr. Herbst.
Can you give me the question?
Any connection with vascular compression syndromes? That's
So that is a concept that Dr. Jose Luis Simaro and I presented on a number of different occasions, and he has given me a bunch of really cool data. I just haven't had time to process through it, but what he is, so originally we were looking at like the amount of tissue. So if you see that there's a lot of tissue around the lesser saphenous vein, which runs down the back of the calf, or the greater saphenous vein that runs on the inside of the leg, those veins are in compartments. And if you grew a lot of lipedema tissue, for example, in those compartments, that would squeeze the vein, and that would push the fluid back into the tissue and possibly dilate upstream veins. Upstream veins. But what I noticed is that I saw some ladies who definitely had a lot of tissue in those compartments, but I saw some that didn't, but I still felt they had compartment syndrome. So what he's done is he's actually looking at the stiffness of those compartments, how fibrotic they are. And you know that a lot of ladies with lipedema can have very fibrotic tissue. If you make that vascular compartment super fibrotic, it's not going to function as well either. So I think there's 2 parts to that vascular compression syndrome, and we hope to have that data out sooner rather than later. But I do think it plays a role, and we have the American Vein and Lymphatic Society meetings coming up, and Lindy McCutcheon and Carlos Zelaya collected a bunch of data on vein disease in women with lipedema, and it looks like the majority of women with lipedema have some kind of vein disease. So it's not surprising that these 2 compartments are going to be affected. And his name is Jose Luis Simaro, Simarro. And he's from Madrid. Sorry about that. Whoops.
We have a couple questions that one is about she's had breast cancer, and she's being asked to start on endocrine therapy, and she's fearful it will increase her lipedema, and so
there is some data that the aromatase inhibitors will increase edema, and I've worked with a number of women who came to me and said, I think I'm getting more edema. And I said, well, there's, not a lot of data on that. Let's take a look. And sure enough, if you look hard enough, you do find that the aromatase inhibitors can increase edema. And so I think the goal for you is to ramp up your manual lymphatic drainage, both your work with professional therapists, but also yourself, to consider an intermittent pneumatic compression pump so you can pump at home, and to make sure that you wear your compression. And, Dr. Wright loves compression garments for lipedema. The higher the compression, the better, according to him, the compression level.
Well, I would say, within reason.
So, but like if you're regularly wearing like a 15 to a 20, maybe you want to wear a 20 to 30, or if you're regularly in a 20 to 30, you could maybe consider doubling up or moving up to a 30 to 40. But definitely work your manual lymphatic drainage harder. Maybe get in the pool more, make sure you're exercising and eating well, and then a pump and compression garments. And I've watched ladies, and they work hard, but they do really well, and they come out of it without any new lipedema. So I think you can do it too.
Yeah, I mean, we may just the whole thing of hormones is such a touchy or kind of it's complicated. We don't fully. But that's, I may be getting a little aside, but I do, I get a lot of questions about hormone therapy.
Me too.
And
we don't have very little data. The only really decent data that's come out is from Sarah Al-Gadban in the literature. And, the problem is that there is more than one type of estrogen receptor. Yeah. So you're looking at, estrogen receptor alpha, estrogen receptor beta, and then the non-DNA binding receptors. And then you're looking at estrogen, progesterone, testosterone,
right.
Cortisol, growth hormone. So it is very complicated, but I think more people are going to be working on it, and we should have more answers within the next 5 years, I would say.
So yeah, but I just want to say we don't know for sure. There's no clear correlation with just plain estrogen or progesterone levels and lipedema. At least it hasn't been observed. And then but we always recommend if you use any hormone replacement therapy or any hormone or any HRT or birth control, that use the absolute lowest dose and be very cognizant, because it could worsen your lipedema.
And the other thing I would say, add to that, is whenever a man starts testosterone, we monitor his testosterone levels very closely. But women with hormone replacement therapy, we go, here's your pill, see you later. And I think the most important thing you can do is to have someone monitor your estrogen and progesterone levels so that you're, within the normal range, but you're not in the highest aspect of the normal range. But at least you're in it. And you're not below it or above it.
So do you see now wants to know when the ICD-10 would be active? Well, first of all, we don't even know it's going to be approved. So then it would be a year or two at least. Yeah.
Yeah. So what we're looking at is we present it on September 11th, and then it opens up to public comments, and then we have to address the public comments, and then it might get presented again in March, and then I don't know where it ends. So I'm kind of I'm learning that myself.
Yeah, but it wouldn't be right. It would be, it wouldn't be for at least at the best would be a year, and it probably would be 2 or 3. These things, like normally for a CPT code, it gets approved and then it's the next year before it's implemented.
Yeah, I can find out. I think that's a really great question. And after we've finalized the submission today, so we have the final submission, and now I can ask, hey, how does this work? So
Yeah.
hopefully we'll have some more information for you on the next live webinar.
if we're so lucky.
Yeah.
So I just got this question about the weight loss, the GLP-1s, the Ozempic and Tirezepatide and do they help or hinder? I'd like to start with Dr. Herbst, and then I have my thoughts as well.
Okay. So I definitely prescribe quite a bit of Wegovy and Zepbound. And Wegovy is the semaglutide and the Zepbound's the Tirezepatide. And those are for the treatment of obesity. And I have prescribed Ozempic and Mounjaro, and those are for the treatment of diabetes. If there is diabetes or I feel like there's so much insulin resistance, we got this in the bag and I can say you have diabetes. And in general, I have seen just incredible transformations. Pain goes down, body tissue goes down. It takes a while, and it leaves behind this, like some lipedema tissue. You still have the lipedema shape left behind, but and maybe it's reducing some of the lipedema tissue too, because it just takes longer to reduce fibrotic tissue. So it's going to reduce the low-hanging fruit, which is the, less fibrotic fat first. But it has definitely made a huge difference in the lives of a number of ladies with lipedema. Some of them are unable to tolerate it, especially if they have a slow gastric motility associated with a connective tissue disease like hypermobile EDS or just hypermobility in general. And they can get a lot of nausea. And some of them don't lose weight at all.
Right.
And that has been published in the literature that some people just don't lose weight. And that probably has to do with the GLP-1 pathway. And some of them have had a lot of hair loss. That's kind of a big deal. So we start scrambling and treating their hair loss. And then it comes back. It does come back. It's kind of angst provoking for a while, but it does come back. And then they go on their merry way. They go up to their maximum dose, and then they come down in their dose and are on a maintenance dose and are doing very well. I haven't had a lot of them come off of it. So the story is that if you do come off of it, you gain 2/3 of your weight back. I just haven't seen anyone who's been treated for a long time come off because they're still too new.
So I also have very similar thoughts about these semaglutide and Tirezepatide. I've also seen this help a lot of ladies with lipedema. And also, in addition to the weight loss, and again, it's not just to be clear, these medications are not approved for lipedema. They're approved for obesity, as Dr. Herbst said, and they and any weight loss helps lipedema for sure. But Dr. Herbst, as she said, and I also see it actually improving the symptoms of their lipedema, their less tenderness, less swelling, and the lipedema tissue. I do see it reduce when they're along with weight loss. Not again, but it's not 100%. There are people who don't respond as we hope. And I would just add on the hair loss side effect is that we are real sticklers about making sure people get enough protein. So almost all of the side effects are dose dependent, and especially when you're just starting the medication, and then they sort of go away or lessen. They either go away completely or lessen as you get accustomed to them. And a lot of also the other things are that some it suppresses the appetite so much that some people don't eat at all, and that's when you start to feel weak or something like that, and that can happen. And it's really just a matter of making yourself eat, and especially eating healthy. So it does Dr. Herbst and I both believe very strongly about, an anti-inflammatory, low carb, quality food diet, and, quality protein diet, emphasizing quality proteins, not processed, meats and though if you include that in your diet, that definitely, helps the side effects, and I would think are going to help the hair loss too, because we do know hair loss is a common side effect or complication of protein, of inadequate protein intake.
Well, the other thing that we, need to point out is that anytime you lose, well, not anytime, but many times when you lose weight, you lose muscle too.
Right.
And so I think one of the most important things, in addition to making sure you're getting enough protein, is to be doing exercise and, weightlifting, walking, getting in a pool, but really trying to continue to build your muscle and slow that loss down.
Yeah. So now, which brand is better for lipedema, Wegovy or Zepbound? I mean, neither of us can answer that. So again, as Dr. Herbst explains, the Zepbound is the Tirezepatide, and then Wegovy is the Semaglutide. And I think they're both effective. They both work. I can't say there's a better one. I would say if they're in the studies that are published, people with the Zepbound or Tirezepatide lost a little more weight, and so I think they're both very effective, and so I think, and they're both very good. They all have so many other benefits to them, including reduced risk of heart disease, reduced risk of stroke, reduced risk of kidney disease. I mean, that I wouldn't, these are game-changing medications for people with those risk factors from obesity.
Mm-hmm.
Yeah. Trying to get some other so I'm going to put this one up. Let's see. Does estradiol pose a problem?
Don't know. What people are thinking is that it's not the estradiol, it's the receptors. So let's say you had a lot more receptors in your thigh tissue of estrogen receptor. I'm just going to fling this out there, beta, compared to somebody else, then you'd have a greater estrogen effect in your tissue than somebody who had fewer estrogen receptors. It could be something like that. Or it could be that you have a mutation in your estrogen receptors that causes it to be more activated when you bind estradiol. There's just so many factors. So I don't think estradiol poses a problem. What I've seen in my experience is that there's an initial growth in the areas of adipose tissue that make us female. So hips, thighs, buttocks, arms at the time of puberty. And if what I presented at the Fat Disorders Resource Society in April, if a woman, in addition to having those genes or that environment that causes that female fat to grow a little bit more at puberty than other kids, and then has some for example, obesity genes in the family that are influencing that growth, then she's more likely to develop the more severe stages of lipedema than somebody who doesn't have obesity in the family or doesn't have like hypermobile Ehlers-Danlos. So I'm looking at it more as, you know, what got you to where you are now, apart from the fact that you're a female and that you have more estrogen and progesterone. So what are these other factors that have influenced the growth of your fat tissue? Because I don't have the data on estrogen or progesterone or the receptors yet. So it's hard for me to, you know, expound any further on that until we have more data. And once we do, then I think that this question becomes, you know, pivotal. But right now it's, do you have obesity in your family? Could you have an obesity gene that's really driving this fat to grow? Do you have hypermobile tissue that's, once you grow the fat, it doesn't want to go away and it becomes more fibrotic? Do you have an inflammatory disease that's also driving this? Like, do you have a mast cell activation syndrome, or do you have a lot of allergies, or do you have an autoimmune disease that's driving this? So that's kind of how I look at it now. And I want to help those problems that are surrounding the fact that you're a female and that you may have some estrogen.
I'm going to chime in as well. And so as far as hormones, hormone replacement, I actually greatly prefer the bioidentical or the natural estradiol over the other synthetic estrogens, just for a lot of reasons. So and I always are gonna so I do have women who and I do have them who postmenopausal who will, you know, we will say it's okay to use the estradiol, but as low as possible. And but I also, to the receptor thing, I would, it is, the research on this is actually there's actually some, it's complicated whether, we've had some conflicting reports. So it's going to take a bunch of smart people like Dr. Herbst to figure this out. Anyways, so, okay. So Lori, are there any questions from Instagram because I'm not I haven't seen any Instagram questions. Okay. Okay, Lori, we sorry. There's plenty. I'm going to put up this one. Lymphatic drainage with your surgeries with lipedema. Okay. So I am very recommend lymphatic drainage with the surgeries, and as well, in addition to compression so after the surgeries, they're draining for a week or so, and we hold off on the lymphatic drainage till a week after their surgery. And then also the same with the pump. Maybe they can use the pump sooner, even just, if they put it like in a trash bag or something like that. But generally, just because it's so messy, and they, to go to someone's office and be leaking wouldn't be hygienic. So we do, if your self MLD is fine, but as far as the professional lymphatic drainage, we like to wait at least a week or till the drainage is mostly done. Do you want to chime in there, Dr.
I find that to be, about right. I remember when I was with Dr. Stutz in Germany, they his patients got MLD like the next day or even that day, but they're draining them. So that's in a surgery office where they know how to handle the fluid, and because the fluid's everywhere anyway. So yeah, I think I agree with you. And I do think it would, like some pumps are more vinyl based, and those would be, better with leakage, and some are not vinyl based. So, and I think it's okay to do your own self MLD until you can get it professionally or use your pump.
Yeah, so we actually do. I mean, my nurses just milk all the fluid out they can just right there, and Dr. Stutz and Dr. Rappridge, Dr. Rappridge does, or is that Dr. Cornely who does the short stretch wrap? I'm getting them confused, or maybe they both do, but they and then they transfer. It's Dr. Cornley who does that, and then he transfers to compression the next day. But we put them in the compression, just before they leave, so that we're sure that it's going to be contained. Everything's going to be contained. So,
what about whole body vibration? Could you do that?
I think you could. I mean, some people are for the first couple days, they tend to be a little lightheaded, and if as long as they have their strength, they're not lightheaded, I think that's fine. Yeah.
Mm-hmm.
Yeah. So Madison has about the ketogenic diet for lipedema.
Mm-hmm. I have a lot of ladies who are on the ketogenic diet. I do have a conversation that says it's best to go on an eating plan that you're going to sustain. I do not like it when they go on the keto and then they go off it and then they gain weight back. So they kind of yo-yo, and then they go back on keto and then they come off keto. I would rather you maybe not lose as much weight right away as you can on keto, but eat a very healthy, sustainable diet that lets you lose slower, but in a more sustained manner over time. Because the yo-yoing isn't good for the body, because during that yo-yo period, you tend to gain a little bit more weight back than you had before, and the body changes its metabolism to hold on to fat more, and that's exactly what we're fighting against. And I know that a lot of ladies are doing time-based fasting. So they'll, get up in the morning and maybe have a black cup of coffee or tea, and then they won't eat till like 10 a.m. or noon. And then they have a noon meal and a dinner, and then they start fasting again. And time-based fasting seems to be working very well. And we know that time-based fasting increases autophagy, which is when you reduce down the number of fat cells that you have, or other cells. But autophagy, is a good thing. It's remodeling of your body. And that happens on the keto diet as well. I'm just mentioning it for fasting, that there's a lot of data there. And there's conflicting data on fasting. I've heard it's good for you, it's bad for you, it's good for you, it's bad for you. So you have to make your own choice. And the most important thing, again, is try not to lose muscle mass. Keep exercising.
Yeah. So, right. And as far as the ketogenic, I feel pretty much the same way, though. I mean, there are some people that do it and can maintain it, and they do great with it. And so, and I do think it's really about limiting the refined carbs is really most of. So,
and toxins, like don't eat chemicals. There's so many chemicals in things that you buy. Like, for example,
the processed food.
Yeah, my mom was having trouble with chronic diarrhea, and she was going to all these doctors and couldn't figure it out. And turns out there's sucralose in her electrolytes. She just didn't read the package. So anything that you buy packaged from the store, you got to read what's in it.
Yeah. There was a question from Instagram on is there any treatment for congenital lymphedema?
It depends on the type. So if you have, if you haven't formed any lymphatic vessels, that's a lot harder. But if you do have some formed lymphatic vessels, then you can do some lymph node transfer procedures or venous lymphatic anastomosis procedures to try and reconstruct that lymphatic system. And just from working with the microsurgeons who do this kind of thing, they want people early, and they want people who don't have a lot of adipose tissue on their body, because they need to find the lymphatic vessels and the veins and connect them together. So they're very picky about it. And they have BMI limits and things like that. But I would say depends on what type of congenital lymphedema you have.
Yeah. But just to be clear, everybody with congenital lymphedema benefits from compression pumps, exercise, weight control, just all those basic conservative things. And that's the way 95%, 98% of congenital lymphedema is managed.
And there's really no medication for lymphedema, even though they're trying to develop it. And most of the medications they're developing are anti-inflammatory. I will say that I've been using sympathomimetic amines for years, and that includes like dextroamphetamine, Adderall, amphetamine salts, even Vyvanse. And I microdose it. And I know microdosing is like, the word of the day. What are you microdosing? But yeah, I do microdose sympathomimetic amines. And I have a young lady, she came in, saw me yesterday. I started her on 2.5 milligrams of dextroamphetamine, and she's now up to 5. And I think that's where she's going to stay. So 5 tiny little milligrams. And she had a complete water loss.
Yeah.
Her leg heaviness is down. She's walking upstairs again. I mean, she's got her life back. And so and it's unfortunately a controlled substance. That's the thing. I wish it wasn't, because it's so useful. It's the only drug we have, and people don't want to talk about it because it's a controlled substance. But if it wasn't, we'd all be talking about it and everybody would be on it.
Yeah. Can you see that that Deb's thing about the
Yep.
yeah.
So she says that she wants to tell something to her family doctor so that her doctor feels comfortable saying she has diabetes, because she's got such intense insulin resistance, and she's paying out of pocket for Zepbound, but her insurance would cover the Mounjaro, which is the diabetes form of the Tirezepatide, if she had diabetes. And her doctor doesn't know anything about lipedema, and she did have a liposuction with Dr. Wright. There's very clear definitions for what diabetes is. And I think your doctor really needs to follow those. But if you have really high insulin levels and you have all the markers of diabetes, including the acanthosis nigricans of the neck and the underarms, I think Dr. Wright would be happy to talk to your family doctor and tell your family doctor what a great benefit you would have if they would, because you're so insulin resistant. But again, I would need to see the numbers. And so I would feel comfortable with it. And I'm sure Dr. Wright feels the same way. We have to argue on your behalf, and we just want to make sure that we're, that it's a good conversation with your family practice doctor.
Well, but as far as insurance goes, they really, I mean, in my experience, they really don't care. They're really about, they have their things, and they want to limit coverage, and they've actually, in some cases, decreased the coverage for these medications. So it's very complicated, and that's part of the problem with the primary care is also going to be like, this is now, I mean, just today, like literally, they just deny, and they have unreasonable things, like, so we're in our system doesn't work as well as it should.
Yeah. And also, I noticed the other day, I had a patient who did really, really well and on Mounjaro for diabetes. And then they said, well, you lost a lot of weight. You don't really have diabetes anymore, so we're not going to pay for it anymore. but it's a chronic disease. And so I don't think that's right. And I had some harsh words for that insurance company.
Yeah, but we have another after conservative. So this is an Instagram question. After conservative therapies have been tried, wait, can I show that? No. Do you recommend surgery at an earlier stage, or should you wait till it's stage 2 or 3? And the answer is, if you're symptomatic, even at stage 1, and you're doing the conservative therapies, then surgery is completely appropriate and recommended. If you still have symptoms that would help and would experience the improvement with the surgery, then by all means do the surgery. And almost everybody who is symptomatic with lipedema gets significant improvement in their symptoms with the surgery. So yeah, I do recommend doing it earlier stages, 1, 2, and early stage 3, and not before it really significantly impairs mobility. So yeah. And that's actually kind of the point of the paper that that Dr. Herbst and I wrote and got the award on. So and it really,
I think we should just say that the paper showed that the surgery improved quality of life, hands down. It improved pain. It reduced the number of lobules. It reduced the stage. It improved knee mobility. It improved mobility overall.
Yeah. So there was quite, I mean, it had robust and improvements in quality of life, in overall function and outcomes of mobility outcomes, comparable or greater than a total knee surgery. So that's I mean that's very we use the same measure, so that's pretty powerful kind of evidence for its effectiveness.
And their gait normalized in a large percent, and of course their body fat mass went down too.
Yeah. So there's a question, is it best to have 2 to 3 surgeries instead of 1? Well, I mean, that's sometimes one surgery can make the difference, and we saw in our data that one surgery sometimes would make a improvement in their mobility and function. But many women have it in, on their throughout their body and require multiple surgeries. And I think actually these mega surgeries where they do liposuction over the entire body are not. I don't think are. I think there are higher complications, the recovery is much harder, and there's a greater risk of complications. So if there's lipedema in, more than just the thighs, say all over the body, then I would recommend staging the surgeries as most surgeons do. Yeah. This is a great question. Yeah. So if I go see Dr. Herbst, how long do I need to stay in Arizona for testing?
Usually we try and get things done clinically in one visit. So we do a comprehensive visit. We'll do, we'll get to know you. I review everybody's history in the day or 2 before I see you. So I think about what you might have in addition to lipedema or other fat disorder that you have. And then I read everything else because I have you do a long questionnaire. I review your history. I look at your allergies, your family history, everything. And then I meet you. You kind of talk about what's going on and what your goals are for the visit. And then I do my physical exam. We'll look at your veins by thermography. I'll do an ultrasound of your tissue. We get a SOZO assessment, so we know kind of what fluid status you are. So we can get it all done like in an hour and a half or 2 hours, so that you could come in. Some people have flown in that morning, and they fly out that night. So you really need to stay that long in Arizona. And we do have a research study coming up in January with Karen Ashforth, and she's going to be using cavitation therapy to try and improve lipedema tissue. And she's done it before and got some great outcomes. And for that one, you'd have to be in Arizona for a month, but that's a little different.
Yeah, that's yeah.
That's research.
Yeah. So we just have time for like one more question or two. And I'm gonna be so are there any new medications or treatments for lipedema? And that's another that's kind of a tough one.
Yeah, that is a tough one. Basically, what I've been looking for are medications that reduce inflammation. So of course we're using the GLP-1 agonists. I use metformin. I use low dose naltrexone. I use, if I think you might have some mast cell issues, I use mast cell stabilizers, and dextroamphetamine is one of those. And there's also it's a medication that I've just started using called Amlexanox. And that is another mast cell treatment. It's a great anti-inflammatory, and it also increases autophagy. What other new medications are there? I think that's it. I think that's what I got.
So while I got you here, and because are you recommending quercetin for mast cell stability?
Yep. So the three things we usually start if you have mast cell issues are one, an H1 blocker, histamine 1 receptor blocker like Claritin, Allegra, Zyrtec, a histamine 2 receptor blocker, which is famotidine or Pepcid, and then quercetin. I usually recommend you take 500 milligram capsule twice a day, but I also recommend you get some organic quercetin powder and put it into a herbal shaker and put it in your soups, put it in your yogurt, put it in your smoothie, put it in your whatever your food you're having. So you get quercetin multiple times during the day. And that's a natural antihistamine. Pycnogenol is also a natural antihistamine as well.
Yeah. So, gosh, we just have a couple minutes, and and then there's one last question. We're going to say is, that if you have surgery on your legs, can fat return in different places like your stomach or arms? And so, I mean, that is often observed, not always. It all depends on some people after the liposuction lipedema reduction. If they gain weight, they're going to gain weight in the areas where they have more adipocytes. So they've had a reduction of the adipocytes and adipose tissue in an area. The other areas with weight gain will increase proportionately. So it changes the proportions, and that includes the abdomen. So it's very important that that lifestyle, weight control, diet, exercise, all those things are maintained, because it can happen. Yeah. Do you have you want to add anything on that in the last? Yeah.
I think I'm good. I think you're good.
Okay. All right. Well, thank you, Dr. Herbst. This has been just so wonderful, and I really appreciate you taking answering these questions, and I just want to congratulate you again on an amazing paper. And I couldn't, you made the paper, so
I'll say that you guys we're an amazing team, and you guys had such great data. Who could not want to work with you?
Thank you. All right. Well, so thank you, everybody. Thank you for your attention. We're going to try and we'll answer some of the questions we weren't able to get to. We'll get those in the comments, and or at least try to. And that's it. Wishing everybody a great weekend, the holiday weekend coming up, and enjoy your Labor Day, and
don't labor.
Yeah. Okay.
Thank you so much. Take care, everybody.
Bye-bye.
Bye.